please share the whole recording widely, but you can also excerpt your own presentation for your own portfolios and so forth.
Hey, welcome everybody from Memorial University of Newfoundland. My name is Atasham Yunus, and good afternoon to everybody. We welcome everyone to this Creative Nursing virtual launch event hosted by Memorial University of Newfoundland. We call it MUN. MUN is the largest university in Atlantic Canada, and it's located in St. John's, which is the oldest city in North America. And we're very excited to have everybody join us today from around the world. Before we begin the event, we acknowledge that the lands on which Memorial University campuses are situated are in the traditional territories of diverse Indigenous groups, and we acknowledge with respect diverse histories, cultures of Beothuk, Mi'kmaq, Innu, and Inuit of this province. Thank you for the opportunity to provide this. So now I would just hand it over to Marty.
Well, thank you, Adisham. We're very grateful for your university's hospitality in hosting this wonderful event. I am joining you from Minneapolis, and the Mississippi River is right outside my window. You can see it from here. So I am grateful to live within the traditional home of the Dakota people and a land over which the Anishinaabe people and others also moved. They gathered and ate food, rested, died, and gave birth and prayed here, and many still do. I'm committed to honoring their ongoing legal, cultural, and spiritual connections to this beautiful land. On behalf of the editorial board of Creative Nursing, I welcome you to this celebration. I should say Creative Nursing, a journal of values, issues, experience, and collaboration. That's our full name of our journal. And I welcome you to this celebration. This is Creative Nursing Volume 29, Issue number 3. We have a growing community of scholars, thought leaders who are willing to write about the issues that not everybody wants to talk about. We approach challenging issues, as you all know. It's so exciting for me to see the authors in this journal issue who've published with us before, including Cyrus Bethaja, Linda Sue Hammonds, who isn't here yet, but will be soon, Roberta Waite, and Ali Saleh. The theme of this issue of Creative Nursing is revealing the structures that determine health and well-being. We chose this theme long ago, and it's just been so inspiring to see how this issue came together and how each of the articles is connected to that theme. Our overarching theme for 2023 is redesigning healthcare, which we also chose long ago and seem to be catching a wave there. And this whole year, we've been highlighting the structures that support the healthcare workforce. That was issue 1. And those called into question the relevance of the legacy structures that we either have or are stuck with, depending on how you look at it. This issue looks at these structures in more detail, building on our previous contribution to this knowledge. The reason I say that is that in 2016, Creative Nursing, we had a whole year with the overarching theme of determinants of health. We had social determinants, structural determinants, caregiver determinants, and global determinants. The World Health Organization defines determinants of health as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape the conditions of their daily lives. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So I encourage you to seek out those articles from volume 22, and I'm going to see how far we can go in making them available for no pay in the short term. I don't know the answer to that yet, but I'm hopeful we can do that. But those of you who have subscriptions, please do seek out those articles or subscriptions either on your own or through your institutions. In this current issue, the one that we're going to be talking about today, the systems and structures that support our caring are revealed from many angles and many levels. And we challenge all of our readers of this issue to recognize the potential in every system and structure in these articles, the potential for disparities in the provision of our care, because those potentials are there in every single one. After we've presented all the articles, we're going to have a moderated open discussion moderated by Bridget Carter, who is one of our editorial board members, and you'll have an opportunity for questions and comments for individual authors and also about the theme of this issue. We also encourage you to reach out to the authors personally. We'll post the list of corresponding authors' emails in the chat at some point, so please watch for that, and if you don't see it, scroll up because it'll be there. There's also an annotated table of contents that briefly describes each article, and that document, along with the recording of this launch event, will be available as soon as our post-production gets rid of all the glitches, and that'll be on our new website, which will be in the chat, and also our journal's Facebook and Twitter pages. Is it still called Twitter, or is it something else now? It's
Some people call it X now.
X, all right, but I think the address still says Twitter, the address of it, yeah. So as I said, we'll post those, so please look at them and scroll up for them. So I'd like to thank Adisham once more for hosting this event and for his leadership as in the role of editor-in-chief of our journal. So several people who wrote articles for this issue of the journal aren't able to attend today. Some of them because they are in time zones that just did not work, and others the times just didn't work. So I personally am going to be presenting several of them, and we're very glad for the people who were able to present either in person or with a video. So the first one I'm going to present is written by our guest editor for this issue, Dr. Cyrus Bethaja. He's a member of our editorial board, and he's a very busy person. As we speak, he's flying from New York City to Maryland to Minnesota right now as we speak. So if he's like in a loading zone somewhere where he can jump on and it appears, I'll let him talk about his article, but in the meantime, I'm going to be presenting it. Until recently, he has been National Medicaid Vice President for Clinical Policy and Solutions for United Healthcare. So he was positioned to be intervening directly in determinants of health. He's recently transitioned to a position as National Vice President for Nursing at Optum RX. He's a fascinating person, and he's written about his story as a healthcare professional in another article in our journal, which again, I encourage you to look for. It's called From the Concrete Grew a Flower. He is an immigrant who came to this country as a child and has now gone from not having a green card to being an associate degree nurse to being a leader at the highest levels of policy making decisions. So that article is fascinating. His editorial for this issue is called The Power of Resilience While Working to Change the Structures That Determine Health and Well-Being. He starts his article this way: being a person of color, a first-generation immigrant, and a nurse working in a majority white, male, physician-dominated corporate world has created many opportunities and challenges in my career. In combination, these factors have made me feel isolated, but have also fueled a desire to use my lived experiences in a way that can meaningfully help to redesign healthcare. He goes on to say that executive nurses are concentrated on delivering more value to more people at a lower cost than ever before, while dealing with conflict from all kinds of stakeholders, business leaders, other nurses, legislators, and patients and families themselves. And he talks about the power of resilience in helping nurse leaders who are working to affect change at all these different levels: direct care, interprofessional, organizational, and policy levels. And the strategies that he promotes are self-care, which is not as easy as it sounds, building relationships, and that sounds very broad, but he's really specific about who to build relationships with and how to do that, how to seek support, how to maintain a positive attitude, which again is harder than it sounds, and also practicing mindfulness. He says that these things are critical for nurse leaders who are working to make healthcare design a reality. And all the other articles in this issue establish that that is just such a need. Now, our next presenter, I am not seeing her yet, so we may need to move on. Our next presenter is Dr. Linda Sue Hammonds, who's an author of a fascinating article about students in the United States and students in Ecuador collaborating on on an international online experience. But I think we'll just go ahead to the next one. And then as soon as Dr. Hammonds comes, I'm just going to make sure she hasn't emailed me to say that she's not coming. So I surely hope she'll be able to. If not, I'll tell you about their wonderful article. The next article is one from China, and this author just wrote right away to say, I'm sorry, I'm not able to attend. Even if the time zones lined up, she just is too busy. But this is an article, the name of our journal is Creative Nursing, and this is the essence of creative nursing. The name of this article is Application of Mind Mapping in Nursing Care of Neurology Patients During the COVID-19 Pandemic. And the author is Shui Bai. She's the chief nurse at Jingshu First People's Hospital in Hubei, China. So is everyone familiar with mind maps? Have you heard about them in some way? And they're usually used either in nursing, they're used either in nursing education or in nursing project development, where people are brainstorming and wanting to understand a concept so that they can move it forward. But what this group did, this was a neurology unit, a 51-bed neurology unit in Hubei, China, and their patients are at high risk of developing COVID and then having worse side effects and outcomes if they do in fact develop COVID. So what this staff did is they developed a mind map. And it was originally in Chinese, and then our article presents as a supplemental file both their mind map in Chinese and then English translation. So Adisham, are you able to cue those up just so that people can see? This is the original mind map that they came up with, and I'll describe it in a minute. And so that's what it is in Chinese. And then thanks to Sage's, our publisher's commitment to publishing in multiple languages, this is the English translation of that mind map. And it's, I'm just wanting you to see what it looks like, but when you read the article, those are both there as supplemental files. So this mind map, what it does, it helps the nurses analyze and recall information by visually structuring ideas. And actually, they claim that it can improve decision-making by decreasing cognitive effort, which makes total sense to me. The staff use this mind map to streamline and systematize all the links from admission to discharge involved in caring for their patients who were at high risk, as I said. The mind map was posted with the bedside care plans of each nursing team. I think each patient didn't have one, but each team had one that they referred to constantly, so that receiving nurses could quickly and accurately implement nursing measures in various situations during the whole hospitalization. When you drill down and look at these different things, it really is like a decision tree. That's how it operated. And one extra bonus that they mentioned is with this mind map, the medical staff, the docs, could understand what it was that the nurses were doing. They had a new appreciation for the complexity of the decisions that the nurses were having to make, and also including handoffs to other relevant departments. Sometimes when you have tunnel vision, you don't realize all the other departments that are having to be involved in this. So the article includes a report of outcomes, including the fact that no patients or staff developed hospital-acquired SARS-CoV-2 during the time that they collected. It was a matter of months where they collected data, and there were no hospital-acquired infections of SARS-CoV-2. And the mind maps are presented, as I said, as supplemental files. So that's Shui Bai's article. I'd now like to introduce Dr. Nina McEwen, who will present the article, No Health Equity Without Diversity, Strengthening Nursing Programs in Historically Black Colleges and Universities. She'll tell us about her co-authors and about how this article came to be.
Did you want me to go?
Oh, yes, yes.
Okay, sorry. So thank you so much for the opportunity and spending your time with me today. Before I launch into this, I would like to read a little bit of a land acknowledgement that I have here in Cook County, Minnesota, which is way north. It's if you look at the map of Minnesota, it's kind of in the tip of the arrowhead on Lake Superior and the border of Canada. And it is on a different screen, so you will forgive me, please, for looking away from the camera. But I'd like to begin our conversation today by offering a mutual recognition of the land, laughter, love, and sovereignty of the band of the Grand Portage Anishinaabe, along with an invitation to reflect upon how we can transform the historical pain and injustice of intentional erasure of our neighbors into sustainable multi-generational partnerships. The rich tapestry of boreal forest, the noble lakes and rivers, all made more beautiful by dappled sunlight, were seized from the band in 1854 under great duress and protest to the United States. We actively acknowledge our privilege and gratitude to the Lake Superior Chippewa who have come before us and to those who have never left. We would like to take today and meet with reverence and respect for the land and the people. We embrace this opportunity to build relationships based on trust, consistency, and accountability. We offer allyship in a lifelong process of learning and reconciliation. So it's an interesting thing to start a digital space with a land acknowledgement, but I think it's even more interesting in this context to talk about an article that I co-wrote with some wildly brilliant women. And it has the same spirit underpinning it as well. I'm clearly white. My ancestry is European. And I wrote with women who are not white and who, many of whom teach at historically Black colleges and universities across the United States. I had the incredible fortune of meeting them at a healthcare summit last April in 2022, not 2023, devoted to health equity. And I met with them after the summit, and we had a moment where we realized that the Sullivan Commission, which called for greater diversity in nursing and healthcare, is 20 years old, and we're still talking about diversifying nursing and diversifying healthcare. And it was a very animated and spirited discussion, as I'm sure you can imagine. And we came up with the title of the piece before we actually wrote anything else. And it was in a spirit almost of activism, but there's a very serious intellectual trajectory behind it. HBCUs, historically Black colleges and universities, are tiered in terms of four-year schools and two-year schools, just like other schools across the country. HBCU is a federal designation by the Department of Education, and there are several other types of what's called MSIs, or minority serving institutions. And the historically Black college and university was the first such MSI to be designated in the United States. There are corollary predominantly Black institutions, or PBIs, that were identified in 2008, also a formal federal designation. In theory, this designation would set aside congressional funding earmarked specifically to support these colleges that serve minoritized and systemically excluded student groups. HBCUs, however, have been historically underfunded. And as such, they are constantly innovating and creating outside of the standards of other types of universities that do not have the special designation. And drawing on the brilliance of my co-authors, we settled on a few ideas of ways that partnerships between what we could call colloquially predominantly white institutions, or PWIs, and that's not a federal designation, or other types of universities. And these groupings include understanding how representation matters. When students see leaders or even professors or clinical practitioners who look like them, it makes an incredibly huge difference. And hiring and staffing of faculty of color, clinicians of color would be something incredibly important, especially if they could become mentors and sustainably mentor students of color then as they go on their journey. The hope is not only to address downstream issues, but also upstream issues of diversified leadership, fulfilling what the Sullivan Commission called for in 2004. But more than that is building sustainable partnerships with HBCUs led by HBCUs to apply creative applications to higher education in general. For example, holistic admissions and being abundant and generous in allowing for transfer credits for students who transfer in or out of universities' nursing programs. This would be one way to begin removing the structural barriers that exist for students of color, as students of color tend to cluster in geographic areas or regions where the funding for K-12 is sparse, and their families also have concomitant funding issues then of attending school. There are a number of curricular approaches that HBUs could initiate as well in partnership with other schools. And my co-authors aimed very high and identified the NCLEX as creating specific case studies around the social determinants of health to embed this understanding of the nuances and complexities of how race is one indicator, gender, age, etc., impact health of communities, zip codes, and specific regions. For those HBCUs that do not have dedicated clinical space, we suggest having industry partnerships. And these industry partnerships could provide space, training, resources that are otherwise missing from the HBCU landscape. The value proposition is fairly straightforward. If one were to authentically diversify the field of nursing and healthcare writ large, we can then begin to imagine a future where health equity is possible. It starts, however, in training healthcare workers, our nurses and other associated workers to begin to address elements of structural racism. So that, in a very short nutshell, is a capsule of this article, and I'm willing to address any questions when that time is appropriate. But thank you so much for sharing your time with me.
Thank you so much, Nina. She and several colleagues have contributed an article to the next issue of Creative Nursing, volume 29, issue number 4, coming out in December. The theme of that issue is about marginalization. And that article is called Centering Health Equity Through the Social Determinants of Health, Interprofessional Education, and Sustainable Partnerships with Historically Black Colleges and Universities, Envisioning Upstream and Downstream Impacts. So please watch for that article. I see that Dr. Hammonds has been able to join us now. She said she had trouble entering the meeting, and I just want to make sure that nobody else is trying to get in. You would know that, Adisham, right? If
Yeah,
anyone
so
else.
I would know that. I think it usually
Okay.
happens because like WebEx is new to a lot of people, so they have to
Okay.
either download it or join through the browser. So I apologize.
Oh, no,
Could
that's
have
all.
done it through Zoom.
So Linda Sue, are you going to be on camera? And can you hear us?
I can hear you, and I'll start my video.
Okay.
Okay. Hi, everyone.
Hi. Are you back home now?
No, we're in our Airstream travel trailer in a campground in Ohio.
All right. Well, we're glad you're here. Go for it.
Okay, so actually, I sent a video. Do we have that?
Do
I
you
sent
have
a
it?
vid.
Yeah. Can you just do it as a screen share?
Let me pull it up.
Yes, so if you click share,
Yeah, I don't have it pulled up. Let me pull it
Okay.
up.
Yes.
Um,
This is her co-author, Sarah Newman, who is down in Ecuador, or maybe she isn't down there right now, but that's where.
yeah, she is.
Okay, all right. Well, I'll just tell our audience then, The name of your article is Diversity and Inclusion in Mental Health, a Collaborative Online International Learning, or COIL, experience.
Yes. Okay. And I'm just about there.
Take it.
We've got times. We're just very glad that you could attend.
So let me know when you've opened the video and you're about to share, because we'll have to do one quick step in order for others to see and hear the recording.
I'm sorry, I thought you all were gonna pull it up. I had I'm not finding it. Maybe I'll just go ahead and talk.
Shall I?
Marty, you can, while they start talking, do you have the video? Because I didn't receive that video. If you can send the video, I can download and I'll play that.
That was the one
Yeah,
where
I had sent it to
yes, and I forwarded it.
Marty.
I forwarded it to Atasham, and it was rather large.
Yeah,
So
because like my university email wouldn't accept more than 25 MB.
Yeah, well, let me just go ahead and speak.
Yes.
Yeah. So I guess we can go back to just there we go. Okay. So this is a project that was done between two universities. It is the University of South Alabama in Mobile, and then the international participant was Universidad San Francisco de Quito in Ecuador. And we did this project as part of a COIL collaboration. COIL stands for Collaborative Online International Learning Experience. And this COIL methodology was developed at State University of New York. And it's been over a decade, probably going on 15 years now since they first started this program. And any faculty and students at any university can participate in this. And what they do is they help you to hook up with somebody, a professor and that professor's class in another country. So it enables the students to have an international experience without ever leaving, their home campus or their home university. And so we did this project in 2021, fall of 2021. And it was very interesting because my students were graduate students in a psychiatric mental health nurse practitioner program. And her students were undergraduate students. And they were from a variety of disciplines taking a required course in English and rhetoric. And the course is conducted in English, even though, they speak Spanish mostly at the university and in Ecuador. And so we had a very wide range of students who were involved. And Dr. Newman, Sarah Newman, and I set up a program where they were able to interact together via the Canvas platform. Some of you, if you're in faculty, may be familiar with the Canvas platform. And there were some readings and some videos that they watched, and there were discussions associated with the readings and the videos that the students participated in asynchronously. So it was easy to do, even though we were in different countries. And it was during COVID too. So it was great that we were able to use the Canvas platform. So the students learned a lot about culture and diversity in mental health. That was the topic. And the way the COIL collaboration works, the students get credit in the class that they're taking at their own university. So the writing assignments and the speech assignments in Sarah's classes were based on these culture and diversity themes in mental health. And our students didn't get credit in the class this time at the University of South Alabama. Because they were nurses, we arranged for them to get continuing education units for participation in the COIL. It worked very well. And then after they learned about these things, we divided them up into groups to work on a group poster. And we made the leader of each group one of the graduate students. And so they were kind of guiding things as they were developing their posters. And then what we arranged to do, we did a mini conference. And we invited other nurses, we invited faculty from both universities, other students from both universities, so there was an audience. And we did this live on Zoom. And Dr. Newman and I did a presentation about the COIL experience to introduce others to what it was that we were doing. And the students presented their posters. And because she had the English and rhetoric students, we had them be the speakers for presenting the posters. So it worked just really well with each group having a participation that was appropriate for their level of education and what they were trying to accomplish in their classes. And we offered continuing education credits to nurses who attended the mini conference. And yeah, it was just really, really fun. I forgot to tell you about the icebreaker that we did. There's this thing called River Runner. And if you Google River Runner, you will be able to pull this up. And with the River Runner, you can drop a drop of water on anywhere on the globe, and it will follow the water pathways to the ocean. And that's what we used as our icebreaker. We had each student drop a drop of water, not at their university, because obviously everybody's would go the same place, but their home community, wherever they were from. They dropped a drop of water and they followed it, and they described in the discussion where this drop of water went. And it really just opened up a lot of discussion about watersheds in Ecuador and in the United States. And the students got to talking about landmarks in these places and museums and cultural activities available. And this simple drop of water activity opened up the discussion for the rest of the semester. And look it up. You'll sit and play with it for a long time, dropping water here and there and seeing where it goes. And sometimes it's surprising. Nina, you're from northern Minnesota, up there in Cook County. Yeah, my husband and I have been up there. And if you drop some water there, it doesn't go to Lake Superior, where people think it might go. Where does it go? Do you know? Hudson Bay. Yeah, water dropped in Cook County goes to Hudson Bay. It does not go to Lake Superior. So, that's the long and the short of it. It's something that you could get involved with if you're an educator. if anybody would want to contact me about that, I know that Marty has my contact information.
We're,
I could get it to you. I'd be happy to.
well, for one
Um,
thing, when you see all the articles, each of your
And it's
articles,
there.
it is there.
Yeah.
Also,
So-
we're going to put one other, or we're going to put it in the chat. So Linda, so I truly apologize about the video. I'm sorry if
Yeah,
it's
and
getting,
I can't. I don't know where I have it in my files.
oh,
It's like I couldn't find it
well,
quickly. It's
so if
there.
okay. So if we're going to keep looking, and actually, if you look in your sent items of your emails, it will be there because you sent it to me.
Absolutely, we
Yes.
did. We did.
So
Yes.
so we'll look for that. But in the meantime, I just wanted to mention, because I wasn't sure if you had mentioned these four things, that the four areas that you talked about were
Yeah, I couldn't recall them in my head.
so you didn't know you were going to be tested on this material. So the four, and we can talk about this later in the Q&A too, but the four were eugenics and cultural bias in research, culture and mental illness, and institutional and care policies. So when you read the article, look at the resources, because there's a grid showing each week and showing what resources they used. Fascinating resources. There's a book that's actually was published in Minnesota, but it's called The Spirit Catches You and You Fall Down. And it's about the
Yes.
Hmong community and the kinds of cultural misunderstandings that can happen when you have two cultures that are very, very different. So I refer you to that. Well, Linda Sue, thank you so much. And actually, Asham, if you keep looking, and Linda, if you can find it and
Yes, I
send it
will.
perhaps as a Google Doc,
Yeah,
would that
Google
work?
Drive would work because
Okay.
then I can
Then
access
Yeah,
it.
it was okay.
we
I'll
definitely,
try.
yeah, we'll definitely look for time to have that.
Okay.
So I'm going to move along, and we actually are right. We are on time. So if we find it,
Okay.
we can do that. The next one is another one that I am presenting. The author was unavailable, but this is another very important article. And this is one where I will have a visual at one point if Adisham can cue it up. This is an article by Phyllis Matthews and Christina Blyer, who are both at James Madison University in Harrisonburg, Virginia. And they are both women's health caregivers with certification in that area. And this article is called Developing a Decision Aid for the Care of Persons After Sexual Assault. The reason it fits so well in this issue is because this really is a structural tool, and it's meant for all kinds of people to learn from, but it is meant to be used by early responders. I won't just say first responders. We think of first responders as EMTs, police, firemen, and so forth. But the early responders in cases of sexual assault aren't just those people. It also includes people in staff of emergency departments and clinics where people who've been sexually assaulted may present. So if you just take a look at this and then picture, if you are a person who has sustained that, this is the kind of thing that will be used, not necessarily handed to you and say, here, read this, remember it. But this is these authors take on what will be helpful for these people. And it's based on the neurobiology of trauma, which is the physiological and psychological effects of trauma, particularly its effects on memory and cognition. The idea that if someone who has been assaulted isn't making total sense or can't remember what happened or is being inconsistent in what they are reporting, there is a physiological and psychological cognitive reason for that. And so to expect them to be making decisions in these early minutes, hours, and days after they've had this traumatic event is unrealistic and unreasonable, and they need help in walking through these decisions. So these early responders need to provide care that acknowledges the impact of the trauma and responds without re-traumatizing the person. We've all heard these nightmare stories of how the first thing that happens is that the event is re-traumatized, and it responds by focusing on validating the experience, saying, yes, this happened to you, along with safety, cultural awareness, trust, and collaboration. So decision aids, if you aren't familiar with this term, it's a decision aid. It's a very specific term. It's a tool that is useful, particularly in these kinds of events. These tools state that decisions that need to be made or considered anyway, maybe you don't need to make a decision right now, but you need to consider it. So these decision aids list the decisions that are going to need to be considered. They provide information about the options, including the benefits and harms, and also the option of not deciding. And they help the patient recognize their personal values in relation to those options. So based on the understanding of the neurobiology of trauma, this decision aid incorporates a written tool, which is what you're seeing on the screen now, that provides education and information to prepare the person to make decisions that are important to them within a trauma-informed environment. So this is the tool that the authors developed, and it's included with the article as a supplemental file. I really want to honor these authors for writing about a subject that some people, even many healthcare professionals, don't want to talk about. So next, I'd like to introduce, I'm happy to introduce Dr. Jenny Hoffman, who will tell us about her co-authors at Eastern Michigan University in Ypsilanti. Can I tell them, Jenny, my grandma, Flora Victoria Potus, graduated from that college in like 1902, when it was called Ypsilanti Normal School. That was the name then for teachers' colleges, and it's now Eastern Michigan University. Their article is called An Innovative Community Health Nursing Virtual Reality Experience, a Mixed Method Study.
Thank you for having me today. My name is Jenny Hoffman. I am a professor of nursing at Eastern Michigan University and a senior member for the Center for Health Disparities, Innovations, and Studies, and I'm also a nurse practitioner working in local public health. My co-author, Suing Wu, is professor of nursing, also director of the Center for Health Disparities, Innovations, and Studies. And my other co-author, Grigoris Argyros, is in the Department of Sociology through the College of Arts and Sciences at Eastern Michigan University. They are not able to be with us today, but they're here in spirit. In our study, we implemented and evaluated a custom VR case amongst undergraduate pre-licensure nursing students. Our sample size was 100 students. Our VR scenario involved social determinants of health and cultural competence with a focus on the Asian American community. First, students completed a consent, then they did the then the pre-brief, and then they had the VR scenario in which some of them either participated with the headset and hand controllers, or alternatively, they watched while their peer interacted with the headset and hand controllers. Then they did a debrief session, followed by a post-test and evaluation. Specifically, the simulation effectiveness tool modified was what we used. Quantitatively, what we found was that scores increased by the post-test, indicating an increase in knowledge had occurred. The SET-M showed that the majority of students strongly agreed that all phases of this VR experience helped their learning and confidence. Qualitatively speaking, we learned what the students found to be most helpful and why, and the benefit they saw of this VR on their nursing practice. And in conclusion, we found that the VR can help to augment community health nursing education and increase their preparedness for practice. And if you're interested, I'd like to show you a link. Do you mind if I put it in the chat?
Please go ahead.
Okay. I'm going to share with you a link for the Eastern Michigan University VR program. If you're interested, you can go to this website and you can see a recorded VR that is actually the one that I'm talking about in this article. And there are also various resources to assist faculty if they would like to utilize this or even a similar VR scenario in their program, including the pre-brief, debrief forms. So if you are interested, I would encourage you to take a look at that website. I'm sorry, I can't hear you.
I was being so respectful that I muted my. When we decide whether to accept an article, one of the things that we look for is creativity. And the way that these authors used virtual reality, as they begin their article by saying that in nursing education, non-acute care often gets the short end of the stick or the fuzzy end of the lollipop. So even concentrating on teaching community health nursing is a departure, is creative. And then to use virtual reality to teach that is another step up in creativity. So that's one of the reasons that this article really lit up for us, and we're very glad to have been able to publish it. And it is structural. I mean, it's a way of exposing students to structure, and it's a way of building a structure to teach students about that. So, well, thank you very much.
Thank you.
So another one that I am going to present is now by international authors who were unable to attend. And they also said that they would like to have attended, that the time would have worked for them, but they just had too much on their plates and were not able to. So I'm telling you about this one, which is also extremely creative. This is an article, and the title is "The Effect of a Diabetes Self-Management Mobile Application on Self-Efficacy, Self-Care Agency, and Self-Care Management Among Patients with Type 1 Diabetes Mellitus." And these authors are from Amman, Jordan. One is Dr. Arva Masada. She's an assistant professor of applied science at Applied Science Private University. And the other author is Ali Saleh, who's an associate professor in the School of Nursing at the University of Jordan. Dr. Saleh has co-authored two previous creative nursing articles. One is about the concept of using concept mapping to teach nursing students critical thinking, very creative. And the other is about readiness-based implementation of electronic health records. If you're going to implement EHR first, you need to find out if people are ready for it, because if they're not ready for it, your implementation is not going to work. So he has a broad scholarship in nursing, and it shows in what he's submitted to us. This current article is about a mobile app about diabetes. And just to refresh our memory, before 1920, diabetes was a fatal illness. But now it's a chronic disease that people can live full lifetimes with, but it needs education and support in self-management to help these folks make decisions about their treatment plan, do their self-care management activities, solve problems as they come up, and then collaborate with their caregivers to achieve better health outcomes and quality of life too, which is kind of the bottom line. So this app was developed by experts in programming for both Android and iOS, and the educational content came in Arabic from a specialized center for diabetes in Jordan. It was posted on Play Store and App Store, so widely available, and doesn't need an internet connection even to use. So here's what it includes. It has logs for blood glucose readings, reminders and graphs for glucose that you can set, educational information about diabetes, including the disease, types, complications, and how to reduce the risk of developing them, management, medications, including insulin, monitoring blood glucose levels, diabetes and hypertension, diabetes and fasting. This is an element that, if you think about it, may not resonate as much with people in the United States, but people in other countries where their religions include fasting as a piety and a practice, this would be even more relevant there. And also calories in various types of food. And there are pop-ups that appear twice a day with educational tips about different aspects of diabetes. In the article, there's a sample pop-up page that's included in the article. They evaluated the app. They had 128 patients, which is a pretty respectable, and 128 patients with diabetes. Half received usual care and half had usual care plus access toward the app. And they didn't release the app to anybody else until after their data collection. And then they made it widely available. After 3 months, there was improvement in a test of self-care agency and statistically significant improvement in self-efficacy in the intervention group. And that's an important variable, because if you feel like you can manage your diabetes, that gives you a lot more energy to do these various things that you need to do to manage it. So they conclude that this app can help improve patients' confidence, knowledge about the disease and complications, and their commitment to self-care activities. Again, just totally creative. So now, next, I'd like to introduce Dr. Ryan Shaw. His article is, speaking of technology, Access to Technology as a Determinant of Health and Healthcare.
Oh, thank you so much for the invitation to talk about access to technology as a determinant of health and healthcare. So technology shapes our lives in the world that we live in. The diffusion of computing and across society really provides access at our fingertips to employment, job applications, banking, bill payments, knowledge, and even healthcare services. In fact, applications for housing assistance programs and job advertisements nowadays are mostly published through online portals, and employers often require applications to be submitted via the internet. Social determinants like housing, access to transportation, food, security, and employment really have a major impact and shape health outcomes. Thus, when citizens have a digital identity, really a representation of themselves online, they have better access to all of these services. They can also use increasingly health services too, like electronic prescriptions, follow-up examinations such as telehealth and digital prevention programs. Access to technology and having the digital literacy to recognize reliable information online are critical to making healthy, to be able to make decisions and to accessing healthcare services. Digital literacy and internet connectivity have been called super social determinants of health. And this is because they may influence other social determinants of health. The US and many other countries have made significant progress in the expansion of implementing high-speed internet access. And increasingly, many people have smartphones providing access to the internet. Unfortunately, pre-existing disparities influence the adoption and utilization of these technologies, often leaving disadvantaged groups further behind. This is called the digital divide, which represents the gap between those who have affordable access skills and support to effectively engage online and those who do not. Accelerated by the COVID-19 pandemic, technological advancements like digital health tools, advanced analytics, including artificial intelligence, AI, are revolutionizing healthcare. These tools are called digital health, and they encompass electronic health records, telehealth, online diagnostic tools, mobile health apps, wearable devices, etc., and even tools such as being able to monitor glucose through glucometers and being able to share that information. And when patients have access to tools such as their patient portal, they can access their own health data and really be equipped to have more informed decision making and to be able to discuss care options with their providers. Digital inclusion encompasses efforts that aim to ensure universal access to and the use of these technologies by individuals and communities, especially those facing significant disadvantages. Efforts towards this digital inclusion, access to technology, and digital literacy are necessary to ensure universal access to and meaningful engagement with digital resources. Importantly, the costs associated with equipping individuals to use the internet are significantly lower than treating poor health outcomes that may have been mitigated or prevented with the use of this technology. Nurses play a vital role in promoting digital equity, serving as educators, advocates, navigators, and being able to guide patients through the complexities of the digital health landscape. Nurses trained in digital health will be at the forefront of new healthcare innovation, leveraging technologies that provide access to important health services and improving health outcomes. For nurses, promoting digital equity can advance health equity across patient populations. Nurses, as the largest healthcare profession, have a key role in advocating for digital equity across individual, organizational, and governmental levels. Nurses can advance digital inclusion and bridge the digital divide by advocating for high-speed internet access, emphasizing cost effectiveness of adopting digital health, and empowering individuals with technology, assessing access and skills, and by promoting incorporating social determinants of health into electronic health records. Thank you.
Thanks a lot, Ryan. One of my favorite quotes from your article is, "The costs associated with equipping individuals to use the internet are significantly lower than treating the health conditions that may have been prevented or mitigated with the use of this technology." So, words to live by. We have 2 more articles to discuss, and then we have been able to tee up Linda Sue's video. So what I'm thinking is, why don't we do Linda Sue's video next if we can do that? And then we have one more article that I'm going to be describing to you, and one more where the author generated a video. So this is about the COIL experience.
My name is Dr. Linda Sue Hammonds, and I'm an associate professor with the University of South Alabama. The students that participated in this collaborative online international learning COIL experience were students in the Master of Science in Nursing program in the Psychiatric Mental Health Nurse Practitioner track.
And I am Sarah Newman. I'm a professor of literature and language at the University of San Francisco in Quito, Ecuador. My students belong to a class, a required class at the university in English that also includes writing, rhetoric, and communication skills. They are theme-based, and my theme was disability. Linda Sue and I connected in order to pursue the COIL methodology, the collaborative online international learning model, which allows people to connect classes across the world, in fact. And in our case, we shared the interest in mental health issues. And so that provided us the opportunity to link two very different kinds of classes in one shared group opportunity to compare perspectives on mental health issues.
The course developed at the State University, and it is now being used globally to connect students in universities all around the world. The way that the COIL methodology works is this. You have two different courses in two different universities. The professors from those two courses develop the COIL experience for the students. And then the students participate in the COIL experience, providing an international experience without ever leaving their home. This was very effective for our students. Students do receive for in the COIL experience, and they receive it in the course that they are taking, in which the COIL experience in that.
Once we joined together, we really had a great opportunity to create aims and objectives that fulfilled a number of different kinds of collaboration points. We had students from different countries, different levels of class, graduate and undergraduate, and different language skills. And so this really ended up giving us an opportunity to have them collaborate and share. The materials which they shared and then discussed involved breaking down mental health issues roughly into the first week, eugenics research and cultural bias. Then we moved into cultural bias in research, and from there into culture and institutional care policies that impact diversity and inclusion. After the 3 or so weeks in which they shared those readings, and then they shared their thoughts in on online discussion boards, we asked them to summarize the kinds of things that they'd learned by creating a poster about diversity and inclusion in the area of mental health.
When the students had completed their posters, we had them to present the posters in a virtual mini conference, and people outside of the two courses were invited to participate in the mini conference. Other students at both universities and other faculty at both universities. The mini conference involved, first of all, a presentation by Dr. Newman and I about the collaborative online international experience that we had developed for these students. And then there were poster presentations, but 4 of them related to the content of the experience. There was a presentation by a student who had expertise in culturally relevant care for sexually abused students or children. And finally, Dr. Newman had a final presentation on madness and the insane hospital reports.
As a result of our collaboration, I think both the students and we as instructors really benefited from looking across the many kinds of differences and the diversity that we shared. Different fields, different grade levels, different parts of the world, ethnicities and languages. I think the students were really struck by how different the perspectives can be on treatment, just general understanding of and diagnosis of mental health issues around the world, but particularly in the two countries, of course, represented in the collaboration. I think for my students as well, it was a wonderful opportunity to develop their oral skills. Linda Sue's students were extremely supportive of my students who do get nervous, some of them speaking English with other people. Linda Sue and I both developed our own teaching, both in terms of the content of mental health issues through the sharing, as well as different ways to present the material, either in our own classes or collaboratively. We found that the interactive methodologies were extremely good at helping students think in different ways and from different perspectives. The one thing that I suppose we all struggled with a little bit was technology, but that was sort of a given from the beginning, and everybody was very understanding of those kinds of issues. The result was a really incredibly enjoyable and successful experience. Everyone learned quite a bit. In fact, it was so successful that Linda Sue and I are continuing our collaboration in another course.
Okay, that's it. That's the end of it. And Melanie Baker is here, and she is collaborating with both Sarah and I on the new collaboration that we're in the middle of right now, actually.
That's about environmental justice, is that right? And the mental health effects of climate change? Am I remembering?
Yes, it's about the vulnerabilities associated with environmental justice issues.
Well, thank you very much. And you mentioned at the end of this video about technological challenges. And once again, I apologize for this glitch, but I'm glad that we could play this to fill in from your off-the-cuff presentation too. We have 2 more articles to present, and then we're going to have a Q&A. If I have at least one question that I can raise, but then if there are other questions, we'll have a moderated discussion, and otherwise we will say goodbye. But I have an article that again is from overseas, and this article is from Iran. And it's quite different from other things that we have talked about so far, but I found it really kind of heart-wrenching myself. The title of this article is Helping a Patient with a Pre-Existing Mental Health Condition Cope with Depression and COVID-19 Using the Newman Systems Model, a Single Intrinsic Case Study. This is from Iran, but the implications for knowledge translation and for practice from this article is worldwide. And as you can see, the timing of this particular launch event, which was scheduled long ago, just has not been conducive to our international authors. So I'm honored to tell you about this article. The authors, the primary author is Dr. Golnaz Azami. She's a faculty member in the Department of Emergency Medical Sciences at Kurdistan University of Medical Sciences in Sanandaj, Iran. And that faculty has written several articles for us before. And her colleagues, I can pronounce their names, Bosra Ibrahimi is from her university, and then her colleagues from Ilam University of Medical Sciences, Dr. Ali Ashraf Mosafari, Dr. Mohammad Reza Kafashian, and Dr. Sanaz Azami. This article recounts the care of a person who already had many serious mental health issues and vulnerabilities, including depression severe enough to involve suicidal thoughts. And she was then hospitalized with SARS-CoV-2 infection. As these authors say, with the advent of the pandemic, fear and anxiety about the newly identified pathogen and what could happen when everyone is suspected to be vulnerable can be overwhelming and cause strong emotions, particularly among patients with pre-existing mental health issues. Nursing theories and conceptual models shape our knowledge, and this article, these authors used the Newman Systems Model, which focuses on primary, secondary, and tertiary nursing interventions. And the goal is to attain, retain, and maintain patient system wellness. So they used interviews, they did record reviews with this patient to develop an advanced outcomes-oriented nursing care plan. And this care plan, I'm not going to show it on screen now, but it is presented in the article as a supplemental file. Very detailed and addressing many, many issues. Providing culturally coordinated care for patients with depression, these authors say, requires looking beyond symptoms to comprehensively evaluate the role of stress, vulnerability, and personal factors. And maybe I'm selecting a little too much, but I just want to tell you that is in the article, part of the history of this patient is that her early life, her medical and psychological health seemed good. And then she was forced to marry someone. And that is when her mental health and her life just seemed to begin going off the rails. I'm sure that this is a oversimplification, but I'm just calling that out because the authors called it out themselves, that it seems to be at that point that things in her life became very, very difficult. And then comes COVID. So this article is, again, I think kind of heart-wrenching, but another example of creativity in how do we help these patients with these multiple problems cope with the things in their lives. Our last article is one where the author has prepared a video, and we do have this one queued up. This article is called How Culture Impacts Health, the Hispanic Narrative, and the author is Dr. Mariana da Costa.
My name is Mariana da Costa, and I'm an assistant professor at WSU School of Nursing. This is an exciting time to publish this manuscript as we celebrate National Hispanic Heritage Month, traditionally honoring the cultures and contributions of both Hispanic and Latino Americans. As a Latina immigrant from Brazil, I appreciate sharing the importance of culturally sensitive care in promoting health and wellness and minimizing health disparities among the Hispanic population living in the U.S. The Hispanic population is the largest and fastest growing underrepresented population in the U.S., estimated to reach 119 million by 2060. It's important to note that not everyone in this population identifies with the term Hispanic, Latina, Latino, or Latinx. Latinx is a gender-neutral term, inclusive of all genders, but for the purposes of this presentation, the term Hispanic will be used, while I recognize that some individuals have other preferences. And the Hispanic population is also diverse in physical appearance, traditions, cultural practices, and language dialects. Therefore, identity within this population is multidimensional and multifaceted. So this narrative really aims to introduce some fundamental cultural factors and beliefs in the Hispanic culture that impact health. The role of history should be considered in understanding the best approaches to caring for members of the Hispanic population who may mistrust healthcare providers because of historic events of mistreatment. Past experiences with discrimination, being misunderstood, or feeling disrespected barriers to accessing care. And several health conditions particularly affect the Hispanic population due to cultural and socioeconomic factors, including heart disease, stroke, diabetes, obesity, cancer, and unintentional injuries. Cultural beliefs, language barriers, reduced access to healthcare, and a lack of cultural competence on the part of health providers are among these factors as well. Hispanic people share a rich cultural heritage that includes strong attitudes towards family and religion, and each subgroup has its own beliefs and customs. Familism denotes a close, intricate family support system that includes extended family members often living with or near each other. And familism can be a source of emotional and financial support that can mitigate health risk among Hispanics. The church plays a role in giving spiritual meaning to family and life and community. And fatalistic views are shared by some Hispanic patients who believe that illness is God's will or punishment for sinful behavior, and some incorporate prayers as a healing practice. For members of the Hispanic population, religion sometimes can serve as a protective factor for mental health. However, it can also work against patients seeking proper treatment, as they may attribute their illness to a lack of prayer or may trust solely in godly forces to resolve the disease. Hispanic patients may choose to use home remedies and consult with folk healers known as curanderos or curanderas, rather than to pursue modern medicine. And these folk practices may not cause harm to patients, but nurses and other healthcare providers need to be aware of this treatment, as they may interact with prescribed medications or may even cause harm or worsen the patient's condition. So inexperience with such religious beliefs and customs have led clinicians to honestly pathologize these practices and warranting clinical attention. In some Hispanic communities, cultural norms around gender, such as machismo and marianismo, may influence prevention treatment, patient care, and health outcomes. The construct of machismo, as it relates to masculinity, can have negative connotations associated with dominance in decision-making, aggression, emotional disconnection, womanizing behavior, and misogyny. Now, machismo can negatively impact Hispanic men who may believe that pain is a sign of weakness, leading them to avoid seeing a clinician and to underreport potential severe symptoms. Conversely, marianismo refers to the expectation that women be obedient, reserved, submissive to authority figures, and subservient to their partners, and remain virgins until marriage. Now, marianismo emphasizes that childbearing and household chores are the responsibility of the women, and this cultural belief system may actually discourage some women from making financial, educational, and healthcare decisions without the input of male figures, contributing to Hispanic women's vulnerability to abuse, mistreatment, intimate partner violence, and also low self-esteem. It has been suggested that some traditional Hispanic cultural practices and eating habits contribute to the Hispanic health paradox, which denotes that despite lower household income, educational attainment, and health insurance coverage, various health outcomes for Hispanic people are equal to, if not better than, other racial and ethnic underrepresented groups and non-white Hispanic people, including life expectancy, infant mortality rates, and prevalence of mental illness. Now, health protective factors supporting the Hispanic health paradox are challenged by food acculturation, in which the typical U.S. diet is adopted by Hispanic immigrants. Essentially, the more acculturated Hispanic people are, the higher their body mass index compared to those that are less acculturated. And research also indicates that within one generation in the U.S., the health protective factors of the Hispanic diet are entirely lost. Language concordant care can help mediate language barriers. Language concordant care is defined as care in which patients and physicians speak the same language. Hispanic patients who experience language discordance between healthcare providers convey feelings of anxiety, shame, embarrassment, and worry about discrimination when reporting difficulty with communication. Adherence to clinical recommendations and treatment, management of chronic illnesses, and patient satisfaction tend to improve when Spanish-speaking providers care for Hispanic patients. Barriers to access to healthcare services experienced by Hispanic patients include a lack of transportation, lack of language-appropriate services, immigration status, affordability, and stigma. Lack of primary care services also create barriers to necessary preventative care services, further contributing to health disparities within this population. Stigma around mental health issues within the Hispanic culture creates apprehension and shame related to seeking counseling and other behavioral health services. In the U.S., Hispanic people have the lowest rates of health insurance coverage among all racial ethnic groups. Even when insured, the overall cost of services and the potential of missing work are significant financial barriers experienced by Hispanic people due to the lower income and employment rates compared to other racial and ethnic underrepresented groups and non-Hispanic white people. Approximately 8.8 million Hispanic individuals in the U.S. do not have legal permission to live or work here, and immigration status poses a barrier to accessing care due to skepticism by healthcare providers and public institutions, ineligibility for insurance coverage, and lack of secure sources of income, and fear of deportation. For nurses and other healthcare providers to support Hispanic patients in seeking healthcare services, engaging in preventative care, and maintaining adherence to treatment plans, they must understand the value of personalismo within this population. Personalismo is a cultural construct that values relationships based on warm, caring, and trusting interactions. And trusting relationships are at the root of personalismo, providing safe space for expressing emotions, sharing information, particularly about family, and asking for help. So it's important to note that provider-patient relationships that embrace personalismo may reassure Hispanic patients in divulging pertinent medical information. Meanwhile, health-promoting behaviors may be adversely impacted when personalismo is absent. So a sense of connectedness in healthcare setting may contribute to families' engagement and trust in staff members, providers, and the system as a whole. Improving cultural sensitivity and health literacy are necessary to increase Hispanic people's access to health services in managing chronic illnesses, promoting healthy lifestyles, preventing obesity, and encourage the use of screening and preventative services. For healthcare providers, listening and observing are indispensable tools for assessing Hispanic patients and for building open communication with patients and their families to allow for effective teaching and care. Thank you.
Well, I have to say, Marty and Adasham, that was my DMP student who graduated a couple years ago, and I had no idea that was her this whole time. So what a surprise, a very pleasant surprise to hear her present that article. So I will reach out to her in person and congratulate her on that. And in the meantime, I want to really just thank all of our presenters. You all have done some phenomenal work, and I hope you know how this contributes to our readership. Even if we don't have a lot of people on the call, this will be accessible to many people across the nation, across the world, and they really look to listen to our authors and understand a little bit more about the work that you're putting forth. So thank you so much for that. We didn't have any questions prepared, but I would like to open it up. If there are any questions, either you can just feel free to unmute yourself and ask the question, since we are in a very small format here, or pop it in the chat and I'd be happy to ask that for you.
I just wanted to point out, we're putting the emails for the corresponding authors in the chat right now. There's a question about being able to see this video. This whole presentation has been recorded, and when we're done with post-production, the recording of this launch event will be posted on our website and on our Facebook and Twitter, or whatever it's called now. So you'll be able to see that video. I have some questions, but and also I wanted to say something else. If you thought there were only this many of you, there have been other people attending whom you didn't see on the screen. I just wanted you to know that. So any questions from other people? I can ask mine, but I'll wait and give you a first crack. Also, if you have questions about the ones I presented, I would do my best to answer them.
I have a question for Ryan. I loved your piece. I think it's really fascinating. I'm wondering if you thought about like the Internet for All campaign from the White House and how that might play into your work.
Thank you, and thank you for that question. Yeah, so this is particular to the U.S. Yeah, there's a lot of different investment going in rolling out high-speed internet access, particularly to rural areas. One of the biggest challenges right now, though, is that there aren't people to install the fiber optics. At least here in North Carolina, there's actually money for this, which usually isn't the case, but there aren't enough people to do the work. So now we come into another we now have come into another barrier there. So hopefully that answered part of your question there. But
Yeah, thank you so much. It's interesting how internet service providers define internet access. And I learned through the research on HBCUs, it's not a lot, just as long as like one person within a certain radius has high-speed internet, internet companies can claim that, oh, the neighborhood has it, and that's not true. And HBCUs tend to have very, very limited access to high-speed internet access. And I thought that was a really interesting problem as well.
just to follow up on that, you bring up a really interesting point about the metrics around high-speed internet access. They are poorly defined, and so companies will go with the bare minimum, to your point, to say that an area has high-speed internet access. And that may just be a neighborhood within a census tract. So yeah, there are a lot of problems there.
Brian, the other thing that I keep thinking about with this is our phones. We talk a lot about everyone having smartphones, but I tell you, when I am in the rural part of North Carolina, my phone does not work. It's such a challenge, and I'm assuming that there are very particular carriers for those very rural areas, but it's just, I also wonder about cost. How does that affect access? Because you have this one carrier for this area that is, giving them access to internet and all that other kind of stuff. So I just think there's so many problems with this in terms of, even though people have some of the technology, we're still a long way away from people having really good access.
When I was visiting Nina this weekend up where she lives, my phone froze up. And I'm so proud of myself. I was able to solve the problem by just letting the battery run down to 0, and then it fixed itself. But in the meantime, if I had needed to get a new phone, I would have had to drive two hours plus to Duluth. That's the closest place where I could, have it seem to. And that's a first world problem. I could survive just fine for that time, but still it just goes to show if you are truly dependent on it. Yeah.
Well, one more thing, Marty, just with this, and I wrote this down and now I forgot who said this, but the little blurb I'm about to say to me was so powerful. I really think you should take this little statement and we need to blow it up. Everyone is suspected to be vulnerable. Who said that?
So that's the article from Iran.
That is so powerful to me. I mean, if we went in with that attitude in terms of how we cared for every single individual, that we should just suspect that they're vulnerable and treat them as such and investigate just like they're vulnerable and don't assume. It was powerful to me.
It is. I'll read it again. This is from the article about helping a person who already was in dire straits with mental illness. Then COVID, I don't know if she was intubated, but she was very, very ill in a dedicated COVID hospital in Iran. And these authors say fear and anxiety about the newly identified pathogen and what could happen when everyone is suspected to be vulnerable can be overwhelming and cause strong emotions, particularly among patients with pre-existing mental health conditions, which one way or another could be all of us. That's amazing. I have a question for Jenny, and it's about structure in a way. If community health is your passion, but community health often gets the short end of the stick or the fuzzy end of the lollipop, like I said. How is that for you? How's that for you?
I see it as an opportunity for us to address that need. So yes, community health, public health is definitely a passion of mine. And that is where I focus a lot of my research on and trying to, further improve the education being given to community health nursing students and increase their preparedness for practice. And so I think that, seeing that there is a lack of VR, say, for example, in community health nursing education as opposed to, say, acute care nursing education, I see that as an opportunity of how we can address that need and make it better.
Oh, that's really inspiring, because what you designed, it really was not a low fidelity. It was pretty high fidelity.
High fidelity,
Wouldn't
yeah.
you say?
Yes, definitely.
Mhm.
Absolutely.
Mhm.
So
Yes.
as lead community health nursing faculty, I designed the scenario, and then I worked with a company called Simex, and then they helped to bring it to fruition on their virtual platform. Again, it's that teamwork, right?
Yep.
We all have our skill sets that we bring to the table, and so I was very fortunate to be able to work with that company, and my colleagues and I are very happy with how that successful partnership worked out.
Mm-hmm. Well, and just reading what this simulation was all about, part of the simulation was giving the person the actual shot. And so I think back to my first shot that I gave, where in person, my hands were shaking so much, and my instructor put her hands on my hands and said, I think this wouldn't be the best experience for any of us, and took over. But that's a technical skill that can be learned, but the kinds of communication and cultural sensitivity that you were teaching is something that's where VR really
Yes.
works.
So
Mhm.
the students were able to, for those of you who maybe haven't had a chance to look at the website, the students went in and they did a health history, a variety of health screenings, height, weight, body mass index, blood pressure, blood glucose, blood cholesterol, and then they did some health education and counseling around that. And then they determined the patient's eligibility for and administered the flu shot. And, because it has that, high fidelity piece, it was very realistic. The students were actually able to go through the motions of what it would be to ask the questions to determine eligibility, use the electronic health record, prepare the shot, go through the different steps of vaccine administration. But as with any simulation, there are simisms, right? So it's not exactly the same as actually preparing and giving the vaccine in, face-to-face encounter, but it was very realistic.
It sounds like you got that feedback too. Well, those are the questions that I have top of mind. Are there others? If not, we'll say goodbye. Atasham, do you want to have the last word from Mun?
Well, I was so glad to host this event. I mean, like a lot of people are not super familiar with Memorial University, but one fun thing I would tell about Newfoundland is a lot of people, when they pronounce Newfoundland, they would say Newfoundland. But when I came here in 2015, they told me you cannot pronounce it at Newfoundland. It should be Newfoundland. So they just say it like Newfoundland. So, I mean, that's the final word that I would say. And so glad that I was able to host this event. And unfortunately, our dean wasn't able to make it because she had another appointment. But in future, when we host further events, I would definitely invite my dean over, and she'll definitely be able to join. So thank you so much again for allowing us to host you for this event. And as the editor-in-chief of Creative Nursing, I'm always looking forward to read more papers, and all of these were really great papers, and we're happy to have them published in the journal. Thank you.
Thank you.
Thank you to all our authors. Thank you.
Thank you very
Thank
much.
you. Bye.
Goodbye now.